Welcome everybody. Today we will be talking about everything below the belt. Now this is for the men only in the house. Here's a basic outline of where we're going to go today. We're going to be talking about the abdominal layers and how they correlate to the scrotal layers. We'll be talking about the inguinal canal and then what passes through the inguinal canal. And then lastly, we'll talk about the different types of hernias. We're going to touch upon the three basic types: the direct, indirect, and femoral. So if you're interested in just a single topic here, go ahead and fast forward. I'll try and keep it outlined in 1, 2, 3, 4 fashion, just in case you want it that way. Otherwise, this video will be a good kind of comprehensive basics review for these different topics. So let's go ahead and start with the first topic here. We're going to be talking about the layers. So we're going to first start off with the abdomen. So we've got the abdominal layers. Now we're going to go from external to deep. So pretend that you're going to start at the skin, and then we'll work our way layer by layer down to the deep tissues. Now the scrotal layers will be formed due to the gubernaculum testes pathway. Now the gubernaculum is going to pull the testes down, and as it pulls it down, it's going to pull some layers with it. So I'll cover all that later, but we're first going to start off with the abdomen. So of course we've got the skin, most externally. Next we've got Camper's fascia. Now Camper's fascia is going to be a fatty layer. It's going to be the superficial layer of the external fascia. Just below Camper's is we've got Scarpa's fascia. So we've got Scarpa's fascia. Remember, Camper's is going to be your fatty layer. If you have some abdominal fat, which I do, you're going to have a thicker Camper's fascia layer. So when you're going out camping at night, you need to bring a nice fatty sleeping bag because it gets cold. So that's one way how to remember that. We've got Scarpa's fascia below that, and just below that is where we start seeing our muscles. Your external oblique. Now your external oblique will have a muscular layer and an aponeurotic layer, so the aponeurosis is going to be kind of more of a fascial layer, while the external oblique muscle will be the muscular layer. So one thing of note is, let me get a smaller pen here, I'm going to run out of room. One thing of note is that it's going to form the superficial external ring. Superficial ring. So it's going to form the superficial ring, and I'll cover that in a little bit because we'll have some clinical tie-ins. Just for now, note that the external oblique forms the superficial ring. Now, sometimes you get confused which way the internal and the external obliques go. One way that I remember it is your external oblique, if you're wearing a jacket or a coat, in your external pockets of that coat, kind of, if you stick your hands down into your external pockets, kind of like the pouch pockets of a sweatshirt, for example, your hands are kind of forming a V. So they're forming a V. That's the way your external obliques go. However, if you flip your hands around and you think of like an A, so here's your person, your V will be this way. So you'll be forming a V. So if you stick your hands in your pockets, you kind of form a little V. Opposite, you have your internal oblique. Your internal oblique is going to be the opposite. So here's your little person again. If you form an A, that's the way your internal oblique goes. So the V is your external, the A is the internal. So that's the way, the direction that your internal oblique muscles go. Below your internal oblique, you've got your transversus abdominis. Your transversus abdominis. So one thing I didn't point out was your external oblique is going to form your superficial ring. Next, you're going to have a few more arches. So all of these are going to be part of your inguinal canal. So there'll be arches in your inguinal canal. So the internal oblique will be an arch, the transverse abdominis will be an arch. Then finally we'll have the transversalis fascia, and that's going to form your deep inguinal ring, or the deep ring. Okay, so the main points are your transversalis fascia is going to be your deep ring, while your external oblique is the superficial ring, and lastly, you have your peritoneum. The peritoneum is going to be touching your organs. So if you have peritonitis, it's that inside layer, the most inner layer. Okay, so these are the layers of the abdomen, going from external to deep. Now, one thing of note is that the scrotal layers, don't exactly match up. For every abdominal layer there's not always a scrotal layer. However, remember that gubernaculum is going to pull your testes down. And as it pulls it down, you're going to take some of these layers with it. That's as basic as you can get. So your spermatic cord follows your descent through your inguinal canal, and we'll talk about that spermatic cord later on. But it's that gubernaculum that's pulling the testes down, and as you pull those testes down during development, you'll take some of these layers. So the skin layers are going to be congruent. You're going to have the skin from your abdomen and your skin from your scrotum derived from the same kind of layer. So skin to skin. The Camper's fascia, there is going to be no scrotal correlate. There's going to be no scrotal correlate. However, you are going to have a Scarpa's fascia derivative. So the Scarpa's fascia in your abdomen is going to give rise to your dartos muscle. And also your dartos fascia as well. Now your dartos is primarily going to be involved in the temperature regulation of your testicles. Next, you've got the external oblique muscle and fascial layer. This is going to give rise to the external spermatic fascia. This can also be called the superficial spermatic fascia, so be careful on the terminology, but it's going to give rise to your external spermatic fascia. Your internal oblique muscle is going to give rise to your cremasteric muscle, so your cremaster muscle. This is involved also in temperature regulation and also arousal. So arousal can cause contraction of this cremasteric muscle. Your transversus abdominis is not going to have a derivative. Your transversalis fascia is, however. So this X goes for the transversus abdominis muscle, but your transversalis fascia does. This is going to create your internal spermatic fascia. Okay, and then lastly, your peritoneum is going to give rise to the derivative of the tunica vaginalis. Okay, so these are the basic layers and the correlates. These are pretty high yield topics. Depending on what class you're in, you may be expected to know this, you may not. Just realize that not every layer gets a derivative. The two that don't are primarily going to be your transversus abdominis muscle and your Camper's fascia, while the rest of the layers will give some sort of scrotal derivative, and that's due to that gubernaculum pulling everything down, and you get some layers with it. So now we're going to move on to a different topic. Starting from here, we may be looking at some pictures, and all those pictures that I got were off of Wikipedia, and I have the citation for it on the website, and we'll cover that when we actually look at the picture. But now let's talk about the inguinal canal borders. We're going to be talking about the inguinal canal. The inguinal canal is going to run, I'm going to go back here really quick, is going to go from the superficial ring through these arches that are formed by the internal arch, or the internal oblique, the transversus abdominis muscle, and then finally it'll spit out through the deep ring into the peritoneum. So you're going to trace it. You're going to trace from the superficial ring you're going to go through a couple arches, through a couple layers, and then finally come out through the deep ring, through the transversalis fascial layer. So that's what the inguinal canal does. Now it has some borders, and it has some vessels and some contents that go through it. We'll talk about the borders right now. So anterior border for the inguinal canal. Now we talked about this. It's going to be your external oblique. And specifically it's going to be the fascial derivative, so the aponeurosis. The aponeurosis of the external oblique. Remember, this forms the superficial ring. So your superficial ring is going to be your external oblique. This is going to be the anterior component. So if you're looking at a human body, anteriorly is going to be bordered by the external oblique. Now, the opposite of that is going to be your posterior border. That's going to be your transversalis fascia. Now, the transversalis fascia is going to be your deep ring. So your deep ring is going to form your posterior, while your superficial ring is going to form your anterior. So we're going from an anterior to posterior direction with this inguinal canal. It should be kind of making sense, especially if you've learned this once over through your professor or through your teacher or through a textbook. You should at least have a decent picture of what it looks like. And again, we'll look at pictures in a little bit. So we have the anterior and posterior. Now let's look at the floor. So the inferior border, or the floor border. I'm going to write floor. It could be the inferior border as well. Now the floor can be derived from a few different things. The inguinal ligament is going to be your main floor derivative. This is going to be a derivative of your external oblique. So your inguinal ligament is going to be derived from that external oblique. And then also you can have your lacunar ligament. And this is primarily in the medial portion of your inguinal canal, not as important. I would remember the inguinal ligament. So that's your floor. Then what do you have? You've got your roof, or the superior aspect. So I'm going to write superior. The superior aspect of this canal is really just bordered by this transversalis fascia and the external oblique. So I'm going to write this external oblique, and then also transversalis fascia. Really, it's these three that are going to be your main ones for the borders. The superior aspect is simply just kind of where the transversalis and the external oblique meet. We're going to next move on to the concept of the contents of the inguinal canal. Okay, so now we're going to look at what's actually in the inguinal canal. We've got your vas deferens. Your vas deferens, and that's going to be the route that your sperm travels from the testes during ejaculation. So that's going to be your vas deferens. You've also got lymphatic vessels. Pretty much everything has lymphatic vessels along with it. You're going to see some nerves. You're going to see some arteries. We're going to see some. So I guess we can start. We can start with the testicular artery. Your testicular artery is going to pass through this inguinal canal, along with a whole bunch of other stuff, and it's going to go supply blood to the testicle. A couple other arteries. We've got the cremasteric. Remember, your cremaster muscle was involved in temperature regulation and also stimulation. Then we've also got the deferential artery. The deferential artery, so that supplies blood to the vas deferens, so that should kind of make sense. You've also got the pampiniform venous plexus. So the pampiniform venous plexus is going to be your venous supply. We've got arteries, we've got veins, you've also got some nerves. Primarily, it's going to be your genitofemoral nerve. And More specifically, it's going to be the genital branch. And this is going to innervate your cremasteric muscle. So this genital branch is going to innervate this cremasteric muscle. Also, you've got a couple other nerves. Really, it's just going to be your autonomic. So your sympathetic, your parasympathetic nerves to your testes, and also your dartos muscle. Remember, your dartos was also involved in temperature regulation. So what happens if you have these contents? So all of this kind of travels together. Now what happens if you have an acute injury and it causes a twisting or a torsion of this bundle? If you have a twisting or a torsion of your testicles, it can result in a decreased blood supply. Look, we have artery, we have an artery, we have veins, we have a lot of vasculature traveling through this canal. And if these contents get twisted or torsed or torsion, they can result in ischemia. And testicular ischemia is an emergency. You're going to have an acutely tender testicle, and you need to think of a testicular torsion, and that can be ruled out through the history. So we are going to try something new here. Let's see if I can get this to work properly. There we go. So we're going to be taking a look here at the inguinal canal. We just talked about the inguinal canal, the borders and the contents. So the inguinal canal, this is going to be our deep area. Let's see if I can get a different color. This is going to be our deep area. That's going to be our deep ring, for example. And our superficial ring is going to be over here. So look at how it's going to travel through the Here we have the aponeurosis, so that pretty much fascia from the external oblique muscle. We have an inguinal ligament, which is going to run just inferior to this canal. So I'm going to draw in the inguinal ligament here. And our deep ring is going to be our transversalis fascia. So our transversalis fascia. This doesn't show all the layers correctly. We'll see some layers coming up in further pictures. However, I'm going to give you, here's where I grabbed this picture from. Here's all the rights to it. I did not create this picture. And we'll be taking a look at some other pictures, but I do want to go back to our kind of picture set here. Let's see. So we just covered the contents of the inguinal ring. Now let's talk about hernias. So we're going to go into the three main types. So there's going to be direct, indirect, and then there's going to be femoral. And I've got pictures for each of these because, you know, all the other stuff that I've covered so far is good, especially if you're a master's of anatomy or if you're in an anatomy class. But if you want to actually have some kind of clinical picture drawn in, the hernias are a great place. I mean, we also talked about testicular torsions, but it's really these hernias. This is going to be the meat of this lecture. And we're going to first start off with direct hernias. So I think I organized this in a decent enough fashion. So here we go. We can draw on these pictures. Let's clear this. So we've got the basic outline here. Now I'm going to orient you because this picture is kind of drawn at an odd angle. So pretend now, without looking at this picture, that you're going to take a buzzsaw. You're going to take a sawzall and cut yourself in half. Now you're going to cut yourself through a sagittal plane. You're going to cut yourself through your nose. You're going to go down through your sternum. You're going to go down through your umbilicus. You're going to cut yourself in half. Now over here is going to be anterior, and over here is going to be posterior. So your sacrum is somewhere down here. Here is going to be your pubic tubercle. So your pubic symphysis is going to be this thing right here, right there. So that's kind of an orientation. And then this is going to be kind of the side of the patient. So Remember, this is, so your umbilicus is somewhere right here. Here's your psoas major. Here's your iliacus muscle. Okay, so that's kind of an orientation. We've got the pubic symphysis right there. Let me clear everything. Okay, so let's take a look at hernias. Again, I did not, still learning this, I did not create this image. It was found here. It's for the public domain. So now let's take a look at direct hernias. We're going to be talking about direct hernias. Direct hernias always bring about the word Hesselbach's triangle. What is Hesselbach's triangle? Well, it's going to be an area, an anatomic area in the form of a triangle. Now it's shaded in green here. I really like this image. So this muscle group right here is going to be your rectus abdominis. Your rectus abdominis is going to go from about your pubic symphysis. So here's your pubic symphysis. It's going to go from about there, and then it's going to go up anterior border of your abdomen. So here's your rectus abdominis. You've got some transversalis fascia, transverse meaning it's going in a transverse fashion, so it kind of makes sense. So Hesselbach's triangle, there's going to be three components to Hesselbach's triangle. You're going to have one, the rectus abdominis. The rectus abdominis muscle. This is going to be the medial portion. So this is going to be the medial portion right there. I should probably keep this all in red. So we have the medial portion being the rectus abdominis muscle. Next, we've got another component to Hesselbach's. That's going to be our inguinal ligament. Now your inguinal ligament is going to be a derivative of your external oblique muscle. So this right here is going to be your inguinal ligament. And I think, yeah, here it is listed up here, the inguinal ligament. So next we've got a third border. So the rectus abdominis is going to be our medial border, inguinal is going to be our more inferior border, while our last border is going to be our inferior epigastric vessels, or inferior epigastric vessels. Now, let's think about this really quick. Our inferior epigastric vessels will be right here. So that's going to give rise to our third set of borders, thus creating Hesselbach's triangle. Hesselbach is the guy who found this triangle, or at least named it. Okay, so if in a test question it says you are feeling a hernia and you feel the protrusion through the medial to the inferior epigastric vessels. You feel this protrusion or this hernia through the medial border of the inferior epigastric vessels. What kind of hernia are you going to think? You're going to be thinking direct, because this is just medial to the inferior epigastric vessels. Okay, so now let's move on. Let's actually talk about what a hernia is. I never really covered what a hernia basically is. A hernia is just where a part of your bowel, your intestine, or any really abdominal contents, they're going to leave through a weakened area. They're going to leave their abdominal location, and they're going to leave through a weakened area. That's pretty much all a hernia simply is. We're going to take bowel or abdominal contents and then stick it through a weakened area. So this area right here is going to be a weakened area. Hesselbach's triangle is going to be a notoriously weakened area. So bowel is typically kind of just in this little basin here. It's going to stick out or protrude through a weakening of Hesselbach's triangle, and that's going to be medial to the inferior epigastric vessels. So again, I did not create this image. I do think it is a great image, and if you would like to look at it again, I just got it from Wikipedia, so here's my citation for it. No, I did not create it. Next, let's take a look at another type of hernia. Let me get this all kind of situated. We'll be taking a look at indirect hernias. Okay, so let's take a look at an indirect hernia. This is where bowel goes through your deep inguinal ring. Remember, we've already talked about the deep inguinal ring. The transversalis fascia is going to create that. So we're going to go through the deep inguinal ring, and then we're going to come out through the external or the superficial, the naming doesn't matter, inguinal ring. It's going to follow the path of your contents, of your inguinal canal contents. Anything that goes through the inguinal canal, normally this is going to be the pathway for the indirect hernia. So let's take a look here. We've got bowel. This is going to be the thick thing is just bowel, so small intestine, for example. And what we're going to do is we're going to go through the deep internal ring, inguinal ring. Then we'll also exit through the external inguinal ring, or the superficial inguinal ring. Same terminology. So we're going to go through the pathway. Now, let me see if I can... No. Okay. So we've got... we were going through that deep inguinal ring. We're going to come out through the external inguinal ring, and that is simply an indirect hernia. Well, a direct hernia went directly through layers. We went through Hasselbalch's triangle layers. We went directly through it. We punched a direct hole through that area. Not a hole, but we went through that direct weakening. For an indirect hernia, why it's called indirect is because we're taking an indirect route. We're going through the deep inguinal ring, through that external inguinal ring, then we'll finally go down into our scrotum. So that is why it's called an indirect hernia. We're going to go through that deep inguinal ring, come through the external ring, and we're going to protrude down into the scrotum. So that's going to be our indirect hernia. Direct hernias. If you see a direct hernia, you want to be thinking male. And next, we're going to be talking about femoral. You want to be thinking females. So if you're ever asked a test question, if that test writer has any sense to them, they're going to associate men with direct hernias because it's about 10-to-1 ratio. Men get direct hernias 10 times more. So let's say a weightlifter, for example, comes in with a mass that is protruding medial to their inferior epigastric muscles. It's a male bodybuilder. That is the #1 presentation for a direct hernia. They were lifting a heavy object. They come in complaining of a bulge. That would be a direct hernia kind of history. Femoral hernias are going to be primarily female. And let's actually talk about femoral hernias now. Let me get rid of that stuff. Gotta cover myself. Here's my source. I did not create this information. I grabbed it from Wikipedia Commons. And then lastly, let's talk about another image here. I had to kind of crop it just to make it YouTube appropriate. So I apologize that I have so many windows open. No, I don't enjoy it either. But however, let's take a look at now femoral hernias. So, all right here, femoral hernias. Now it's called a femoral hernia because I'm gonna orient you here. We have our inguinal ligament, So there's our inguinal ligament. Everything else that we've talked about is above it. Remember, our direct and our indirect are going to be above this inguinal ligament because our border for that inguinal canal, the floor border or the inferior border, is going to be this inguinal ligament. So that said, here's going to be our inguinal canal just right above this inguinal ligament. So everything that we've talked about is just above it before. Now we're going to be talking about stuff below this inguinal ligament. Now, I say it's a femoral artery because you're going to have these femoral vessels. You're going to have a femoral nerve. You're going to have a femoral artery. You're going to have femoral vein. You're going to have some lymph somewhere in there, not drawn in. Now, right below this inguinal ligament, just below this inguinal ligament, so a little deeper to this inguinal ligament, you're going to have this femoral ring. And this is where these vessels go. These go through the femoral ring. Now, if you want to feel your femoral pulse, if you stick your hands kind of down by your inguinal ligament, if you go just below it, you should be able to feel your femoral artery pulsations. So you can feel a femoral pulse on somebody. This is where a femoral hernia typically arises from. It's the area where the femoral nerve, artery, and vein go through. So what you'll have is up here in your abdominal contents, you'll have some intestine. If it actually goes through the same route as this femoral artery, nerve, and vein goes through, that would be a femoral hernia. Now, a femoral hernia, like I said, is primarily in females. So just think, if you're palpating a patient's inguinal ligament, just below it, you feel a reducible mass, that could be a femoral hernia, especially if it's in a female patient. Let me clear this, get rid of it. Let's see, get rid of it. Here's where I took this picture. Here's that citation for the picture. Now let me go to my screen here. Let's go back to the first page. We talked about the different layers. We talked about the inguinal canal borders. We talked about kind of where it is. We talked about what goes through that inguinal canal. Then we talked about some hernia disorders. The hernia is either through the canal, so through that canal, which would be indirect. It could be through Hasselbeck's triangle, which would be a direct, so we go directly through a weakened area. Or it could be a femoral hernia. So we're going to take the same path that your femoral artery, nerve, and vein go through. So just below that inguinal ligament, through the femoral ring. You know, this is one of the more difficult concepts in anatomy. If you have any questions, if you think I didn't explain something clear enough and you would like a little clarification, go ahead and let me know. Otherwise, I appreciate any comments you may have on this video, and thank you for giving me your attention today.